Welcome to this Step 3 review on geriatric ambulatory care test-taking strategies, brought to you by Roadmap to Residency. Today we are going to break down the most common question patterns you will see on your board exam for older adults in the clinic. We will cover polypharmacy and deprescribing, full risk, dementia screening, and advanced care planning. The goal here is not to reteach every detail, but to help you recognize the patterns and apply test-taking strategies so you can pick the right answer quickly and confidently. To get the most out of this, make sure you are working through the geriatrics sections of your primary review book and your question bank alongside this video, since that is where you will lock in the underlying content. Here is what we are going to cover today. First, we will learn how to recognize the high-yield question stems that show up again and again in polypharmacy, falls, dementia, and advanced care planning. Second, we will apply specific test-taking strategies for deprescribing, full risk, and cognitive screening questions. And third, we will master the next best step question format as it applies to the older adult in the ambulatory setting. This video assumes you already have some baseline knowledge from your review resources, so our job here is to sharpen the way you attack these questions on exam day. Our first strategy is learning to spot the offending medication, because polypharmacy questions are everywhere in geriatric care. When you see an older patient on a long list of medications who develops a new symptom, train yourself to ask two questions. First, did a new symptom appear right after a drug was started? And did someone then treat that symptom with yet another drug? That is a prescribing cascade. The classic example is a calcium channel blocker causing ankle swelling, which then gets treated with a diuretic. The right move is to treat the cause, not the new symptom. Second, are there high-risk drugs on the list, such as sedatives, anticholinergics, or over-the-counter sleep aids? When the STEM pairs a long medication list with a new fall, confusion, or dizziness, the answer is almost always to stop the offending drug rather than add a new one. Strategy 2 is reading the full risk STEM correctly, because falls are one of the most heavily tested topics in geriatric ambulatory care. The single most important thing to remember is that the strongest predictor of a future fall is a previous fall. So when a STEM opens with a patient who has fallen before, your radar should go up immediately. Other high-yield risk factors that the boards pile into these stems are gait and balance problems, lower body weakness, certain medications, vision impairment, and home hazards. When you see several of these together, the question is testing prevention. For management, remember that the first step for someone who reports a fall or feels unsteady is usually a gait and balance assessment, such as the Get Up and Go test. And the most effective prevention strategy combines exercise focused on strength and balance with a careful review and reduction of risky medications. Now let us go through the high-yield stems you will see again and again. For polypharmacy, the classic STEM is an older adult on many medications who develops a new fall, confusion, dizziness, or constipation. The best answer is usually to review the medication list and stop the offending drug, not to add a new one. For falls and cognition, look for a recent fall, an unsteady gait, or new memory complaints, and remember to reach for the assessment step first, such as a gait test or a brief cognitive screen, before jumping to treatment. And for advanced care planning, the STEM is a seriously ill or older patient where the goals of care are unclear. The best answer there is to ask about the patient values and identify a surrogate decision-maker rather than ordering more tests. These three patterns cover a huge share of the geriatric questions you will face. Let us work through our first practice question. An 80-year-old woman comes to clinic after a fall at home. She takes a medication for high blood pressure, a sleep aid most nights, and an over-the-counter antihistamine for her allergies. She tells you she feels lightheaded when she stands up, and on exam her blood pressure drops when she goes from sitting to standing. The question asks for the most appropriate next step in management. The options are: Choice A, start a medication to raise her blood pressure. Choice B, review and reduce the sedating and blood pressure lowering medications. Choice C, order magnetic resonance imaging of the brain. Or choice D, begin a daily aspirin. Think about which one truly addresses the cause before we walk through the answer on the next slide. Let us break this down step by step. Step 1, spot the pattern. We have an older adult, a new fall, lightheadedness when standing, and a blood pressure that drops on standing. She is also taking a sleep aid and an antihistamine, both of which are sedating and both of which raise her fall risk. Step 2, apply the rule. The rule you must carry into the exam is this: when a medication is likely causing harm, the best first step is to remove or reduce the offending drug before you add anything new. In the older adult, fewer drugs is almost always the safer answer than more drugs. Step 3. Eliminate the wrong answers. Choice A adds a drug and ignores the actual cause. Choice C orders brain imaging that the history simply does not support. Choice D adds bleeding risk without doing anything about the falls. That leaves the correct answer, choice B, review and reduce the sedating and blood pressure lowering medications. Here is our second practice question. A 78-year-old man is brought in by his daughter because of memory problems that have been getting worse over the past year. He has had trouble managing his finances and has missed several appointments. He is alert, his vital signs are normal, he is not depressed, and he is not taking any new medications. The question asks for the most appropriate next step. The options are: choice A, begin a medication for memory loss right away. Choice B, perform a brief office-based cognitive screen. Choice C, order magnetic resonance imaging of the brain first. Or choice D, reassure the family that this is normal aging. Notice the gradual decline with loss of function, and think about what you need before you can act. We will walk through the answer next. Let us work through this answer. First, read the question carefully. We have memory loss over a full year, combined with a clear loss of function in everyday tasks like paying bills and keeping appointments. That degree of decline is more than normal aging, so reassurance is wrong. There is no depression and no new medication that would explain the picture, which means we cannot hand-wave it away. Now, why does the cognitive screen win? Because a brief office-based cognitive screen objectively measures the problem and tells you where to go next. Reassurance ignores a real functional decline. Brain imaging has a role, but it comes after screening points toward a cause, not before. And starting a memory medication before you have made any diagnosis is putting the cart before the horse. The correct answer is choice B, perform a brief office-based cognitive screen. Let us review dementia management for the boards, because the test approaches it in a very predictable way. Before you ever settle on a dementia diagnosis, the boards want you to rule out reversible contributors. Check for thyroid disease and a vitamin deficiency, screen for depression, which can mimic dementia, and review the medication list for anything sedating or anticholinergic, and always separate dementia from delirium. New confusion that comes on quickly, over hours to days, points to delirium, which is a different problem and demands a search for an acute cause such as infection or a medication. Once you are dealing with true dementia, management centers on safety, caregiver support, and planning. Address driving safety, home safety, and a caregiver support plan. For agitation, the boards favor non-drug approaches first, and use these visits to begin advanced care planning early while the patient can still share their own preferences. Here is our third practice question. An 85-year-old man with advanced heart failure and worsening function comes to clinic with his son. He has been hospitalized several times this year. He is alert, and he says he wants to talk about what comes next. He has no written documentation of his wishes. The question asks for the most appropriate next step. The options are: choice A, ask about his values and goals and identify a surrogate decision maker. Choice B, order an aggressive workup for every possible condition. Choice C, tell the son to decide for him. Or choice D, avoid the topic to prevent distress. Notice that the patient is alert and is actually inviting the conversation. We will walk through it next. Let us break down this answer. The classic pattern here is a seriously ill older patient with declining function and no documented wishes, who is alert and willing to talk. That is the ideal moment for a goals of care conversation, and the conversation should be led by the patient's own values while he can still speak for himself. Now, the key distinction: a blanket aggressive workup ignores his preferences and may not be what he wants at all. Telling the son to decide bypasses an alert patient who is fully able to speak for himself, and that is the trap answer many people fall for. Avoiding the topic abandons the patient at exactly the moment he is asking for guidance. The correct answer is choice A, ask about his values and goals and identify a surrogate decision maker. Here is a critical test-taking pearl about the decision-making terms in advanced care planning because the exam loves to test the vocabulary. Know these cold. An advance directive is the document that records a patient wishes in writing. A healthcare proxy, also called a durable power of attorney for healthcare, is the person the patient names to make decisions if they no longer can. And when there is no written directive, the standard is to follow what the patient would have wanted. which is called substituted judgment. Here is the point that wins these questions. An alert patient who has capacity always speaks for themselves, no matter what family members want. A surrogate steps in only when the patient cannot make or communicate a decision. The exam tests who decides and on what basis over and over, so commit these distinctions to memory. That wraps up our review of geriatric ambulatory care test-taking strategies. Remember to review the geriatrics chapters in your primary review book and your question bank, and focus your practice questions on polypharmacy and deprescribing, fall risk, dementia screening, and advanced care planning, since those are the patterns we drilled today. Visit www.roadmap2residency.com for expert tutors and residency advisors who can help you build a personalized study plan and get ready for match season. If you found this video helpful, please like and subscribe so you do not miss our next board review session. Good luck on your exam, and we will see you in the next video.